Hi, my name is Nguyen. I am a emergency medicine and critical care medicine physician. And for this lecture, I'm going to talk about the COVID-19 pandemic, which is currently what we're experiencing right now. So I think it's very important that we know about it. For my slide, at least, I'm going to talk in a emergency medicine perspective. But once we get to the management side, I might, squeeze in some critical care stuff in there in terms of management. My experience with COVID has been mainly, I'm a traveling doctor, and my experience with it has been mainly in Philadelphia when in March and April when we were initially, hit due to the trickle from New York City, and also from my experience in Indianapolis, Indiana as well. I did mainly ICU work in these places, but I've been all over the country in the past few months as well. Okay, so let's move on. Some disclaimer and disclosure. You can read it. I have no financial relationship, and my PowerPoint is not approved for any investigational use. Okay, next slide. So just to give you a little format, we're going to do a little introduction about the pandemic, and then we're going to talk about the pathophysiology because I think that's important, so that we can gear towards the pathophys to management. And then, a few minutes to talk about the prognosis of, patient who survived COVID, and then some current research. Okay, next slide. Go back. The map here is just a map of, this was actually a map from 2003 when SARS or COVID-1 was started. It was also started in China, and because of international travel and all that, it kind of spread all over the world, and it's kind of, the current situation as well. Okay, next slide. So for the introduction, so this is just a update. It was mean to, it's meant to be an update only. You can go to the next slide. As you know, we're currently experiencing this pandemic, and there's rapidly evolving information and data with trials and research. So this is meant to be an update. What I'm talking about today might be different, from a week from now, a month from now. And all the data that we have now, we put together theories, work up how to the prognosis of these patients and how to manage them at the moment. How we manage these patients and our understanding of this coronavirus has been different when it started in December, January. The reason it's important to talk about COVID because in all aspects of medicine, we deal with COVID. It has an unprecedented and overwhelming global effect in terms of public health, the resources, the economic and social impact. As we speak right now, there's really no current effective therapeutic agent or, any FDA or WHO approved, one or, a couple of therapeutic agent. We currently also do not have any vaccine for this. In the last 10 months, we have, just gathered more experiences and data. And as time evolved, so is our understanding and the management of this, disease and virus. So a little bit about the coronavirus. So the first cases of the viral pneumonia was first reported in Wuhan city in China. And I would think that, I think that about 2 weeks later, the Chinese were able to completely map out the genome and found that it was a coronavirus. And it shares like about an 80% genetic similarity, what we experienced in SARS in 2003. And that was, that's why the scientific name for this virus is SARS-CoV-2, because in 2003, it was SARS-CoV-1. COVID-19, COVID, stand for corona virus disease, and 19, as you know, is because we first discovered, these cluster cases in Wuhan in December 2019. However, there are indication that, the virus has affected China and even maybe globally as earlier as, October, November of 2019. The first cases in the U.S. Was about, the middle and the end of January in California and New York City due to U.S. citizen who traveled to China and came back. The initial report to the World Health Organization from China was made in December 31 of 2019. WHO called it a global health emergency as there's more cases over the world on January 30, a month later, and they call it a pandemic 3 months later in March. The last pandemic, just to let you know, was the swine flu, the H1N1 in 2009. So next slide. So a little bit of comparison to the previous outbreaks. If you look briefly at the first column, the Spanish flu has a pretty significant mortality. And in the last decade, I would say the H1N1 virus and the coronavirus account for more than 1 billion deaths. With the Spanish flu right now, it's currently the highest mortality. This is not accounting the current HIV and AIDS epidemic as well, which have killed over 32 million since it was first identified in 1981. And if you look at the second column, the Spanish, just talking about viruses, the Spanish flu killed about 50 to 100 million people, and cases reported then was about 500 million. And then the Russian flu, the Asian flu, and all that, involving H1N1, H2N2, and H3N1 account for, several millions mortality. And then in the last decade, we've been dealing with SARS, which is COVID-1, starting in 2003. MERS, or the Middle Eastern coronavirus in 2012, and then this one, SARS-CoV-2. Okay, next slide. In terms of mortality, compares to the last two coronavirus epidemic and the H1N1 pandemic, the mortality is, if you look at the SARS in 2003, the mortality is around 9, but then once that ended, we found out that the mortality is actually only 3%. MERS actually had more, higher mortality, around 8 or 9. And this data, the 6% that we currently, noted on the chart, that's data from March, pretty much. Currently, we have about, 35 million cases, and the total deaths is about, reaching, 1 million, more than 1 million now. And on the bottom side, if you have time, you can read through it. Read through it, some basic, statistic. Okay, next slide. So this dashboard is from the Johns Hopkins epidemiology department, and Johns Hopkins right now is the current, what everybody uses for the amount of global cases and the mortality. Now, this number was achieved, if you look at the left corner, September 27, 32 million cases with a global mortality of 900,000, almost a million. Currently, as I'm doing the slide, the number is 35 million, and the mortality cases globally is 1 million. And the US is still leading number of cases on mortality as well. As we speak right now, The current mortality in the U.S. is almost 7,500,000 cases, and with a mortality of like almost 230,000 cases. Next slide. So in terms of epidemiology as well, this virus doesn't really have any discrimination to sex, age, race, or religion. However, there is a tendency with male being more infected than female in terms of cases and also severity of the cases. There's more cases between, the age range of 20 to 60. White being affected more than Hispanic, but overall, there's a higher percentage in minority, especially in Blacks and Native Americans. So this is data obtained, the symptomatic cases, these are data obtained, at the beginning of the pandemic. There's a hospitalization rate of 14%, and out of that 14%, 2% are critically ill in the ICU. And at that current time, the fatality rate is 0.4%. The highest fatality rate that you've been hearing about is anybody above 70, and anybody above 80, they have a 80% mortality. And interestingly, the lowest rate of mortality is in kids, less than 10, with a 0.6% mortality. And asymptomatic infection rate is about 35 to actually 50%. And if you look at the maps on the right-hand side, this is the map of where the most, in terms of cases, the darker red on the above is, where the cases are most, where the cases are highest. And then if you look at the U.S., it's also, show you where the cases are highest as well. Next slide. So in terms of risk factor, anybody who have cardiovascular diseases tend to have the almost, a 5-time more risk in terms of the general population. And along with this is, also people who have lung problem. I would categorize the cardiovascular diseases and COPD as kind of like your highest risk factor. And then your next tier would be your transplant patient, any patient with renal disease, diabetes, and, interestingly, obesity as well, and high blood pressure, which you've been hearing about as well. Other risk factor or other lung diseases such as asthma, sickle cell disease, anybody who immunocompromised, or taking medication that will compromise the immune system, and smoking as well. So in terms of just increased morbidity and mortality, sex-wise, male, gender, age, and then low income, and that factoring into the minority, the reason why minority has higher mortality. And interestingly, in the last two or 3 months, there has been articles out that, blood type can also increase your risk factor, especially type A. And that will increase your risk of death, and also how severe your respiratory, issue will be. And also interestingly, type O, the universal blood type, there is almost like a protective, mechanism where there is decreased symptom and morbidity and mortality. However, the mortality aspect, there's really no significant benefit to it. And the theory behind it, that they're looking for, it's not very clear cut, is the antigen expression on the cells of the erythrocyte or the blood cell. And these antigen expression, antigen are also expressed on the epithelial cells of the airways, particularly the alveoli. And these antigen, which had not been clearly identified, allow, they think that allow improve um, cellular invasion of the virus, especially binding with the ACE2 receptors. Okay, next slide. So this, this slide just give you kind of like a breakdown from the Chinese data in February. And the distribution and kind of like the trend is almost the same as this. It's just the numbers are more, or increase. So when you have time, just take a look at this. Okay, next slide. So in terms of gender, like I say, male gender tend to have a little bit more cases and severity. And with the current research, especially at the beginning and even now too, there tend to be a 2-time amount of cases versus, from male to female. However, this is highly variable, but it's consistently, with all the data out there, that male tend to have higher cases than female. The reason I say that is that, some study, show up 4 times or even 6 times the amount of cases with their study. And this, interestingly, is the same for SARS, COVID-1, and, MERS, the Middle Eastern one. And all of these are, like I say, are coronaviruses. Now, is there like a genetic component? We believe so. However, with the Spanish flu and SARS and MERS, when we found out that more male and female than female were being infected, we found out that, it's mainly a gender-related variable and not so much genetic, even though I really think there is, probably a genetic component as well. But what they found out for the Spanish flu and the previous coronavirus epidemic and pandemic is that, once the numbers are all, when they, pandemic or epidemic is stabilized and resolving, they break down the data and it shows that, the gender-related variable are very important. And they found out that, social economic factor, including occupation, the class you're in, has a, importance. And the behaviors and the roles of the male gender versus the female also play a role in terms that usually the male or the provider and, generally work. And in terms of class, a lot of the male work in an environment where they get more exposure than female in terms of the work that they do. And the comorbidity, there is a consistency in terms of male having more, chronic diseases such as hypertension, smoking, diabetes, heart, related disease than female. So they think that when, taking all these variables into consideration, they think that this is what causing the discrepancy between male and female. But there is a study in the past have shown that women do generally mount a better immune response to pathogen. They produce more antibody, and we think that, it's because of the hormones and especially estrogen. So the current research right now, there's a couple of trials going on that actually, trialing estrogen injection into male and see if, if it helps with their symptoms and mortality. So, that will be interesting to see what the results are. So next slide, we're going to talk about the virus itself. Next slide. So briefly, it's a non-segmented positive RNA virus, belongs to the corona family. It's very widely distributed. I mean, it's the cause of the common cold every cold and flu season in the fall. And it's the most common cause of viral pneumonia because of how widely distributed it is. And as I mentioned, 2003, 2012, and now are all coronavirus related. the mechanism of this coronavirus, in general, all the coronavirus, it binds to the way that it go into these cells is it bind to the ACE2 receptor on the cells, and then get into the, if you look at the illustration on the right, it get into the cell, it get envelop into the endosome, and then through that, it hijack the the replication process of the cell to introduce the virion DNA and reproduce, and then it causes cell death and release of more viruses, virion. And there's and we find out, just like any other viruses, with time it mutates. So currently, there's 6 strand of this virus. However, the virulence of it remains low. And there's ongoing genetic mapping, and there's a site actually that map out all the genome. So if there's any anyone who's interested in, especially microbiologists, can look at it. The first strand was the L strand in Wuhan, but that's disappearing. The most common and widespread is the G strand, which account for almost 80% of what we find globally. Next slide. So transmission, just like other coronavirus, it can get transmitted through the respiratory tract via the mucous membrane. And so this is why, pulmonary is the first organ that it will affect. And there's an incubation period about 5 to 8 days with the medium of 5 to 6 days. And viral shedding in patient can be up to 5 weeks, but that doesn't mean that they're contagious. The mode of transmission, just like other coronaviruses or just viruses in general, is contact, airborne, and fomite. Contact is pretty straightforward. Airborne, it can linger in the air for several hours. Fomite is when the virus actually persists on these surfaces, and they found out that it can be a week, up to a week, depending on, what kind of surfaces, it is. And it's when you're talking about transmission, the reproduction number is actually pretty important, what we call the rho. And the rho for this virus, and if you look at the on the right lower illustration, rho meaning the reproduction number, meaning that if one patient is infected in the blue, it can infect 2, and that's a rho of 2, and that person can infect 2 more people. With COVID-19, the rho, it's actually almost 3, and and the current research showing that it's about 4, which is much more than the seasonal flu. The seasonal flu, it's about 1.5 to 2. Okay, next slide. Let's talk about a little bit about pathophys. Next slide. So the virus get into the cells via the ACE2 receptor through the S-spike protein, and then that's how it invade the cells and replicate. And it's mainly the epithelial and endothelial cells. And then when the virus get into the cells via the ACE2 receptor, it decreases the angiotensin 2 metabolism and level. And when that decreases, there's a feedback loop where angiotensin 1 is decreased as well, but it's a transient decrease. When you have a transient decrease like this, it causes a feedback loop again and increase actually the level of the angiotensin 2, which is what's significant. Increased level of angiotensin 2 causes local mediator release from the endothelial cells. And this local mediator release, especially in the alveoli, causes inflammatory changes, and with time, cellular injury. And through this loop, you actually get a significant rise of angiotensin 2. And eventually, the angiotensin 2 level actually get exhausted and decrease. So initially, you have extreme vasoconstriction, and then eventually you have microvascular dilation. And then you went from a anti-thrombotic mediators to a pro-thrombotic mediator. And this is important to know because this kind of gives you an understanding of the progression of the disease. And the illustration on the right kind of give you a little explanation of visually. So overall, ultimately this virus caused vascular dysfunction and dysregulated inflammation. The virus also caused direct vascular endothelial injury. But it's the localized cytokine release and is what's caused the what you see. And this is what we call the cytokine storm or cytokine release syndrome, which is what caused the end organ injury and ultimately the mortality in these patients. Next slide. Next slide. So we postulate that there are probably 3 stages in this, disease process. The first stage is the replicative stage where the virus enters the cell and start replicating. And this caused, direct injury to the endothelium, like I say, but it also caused a response in the innate immune system to directly destroy the virus. If you look at stage 1, that's the early infection. And that's usually like during day 1 of symptoms to day 5 or 7. And then after that, the adaptive immune system comes into play because, with the activation of the macrophages and natural killer cells in stage 1, the macrophages actually will stimulate B cells and T cells, and that's your adaptive response. And the T cells and also the macrophages will release cytokine. And here, when the viral load decreases because of the innate response, patients feel better. And that's usually like, you'll hear that, they start not feeling well, and then day 5 or 7, they start feeling better, and all of a sudden they deteriorate. And this rapid deterioration is postulated to be the cytokine storm. And then the stage 3, I characterize it into 2, and have been theories about this. Stage 3A, the first part of stage 3 is what I consider the pulmonary, even though here it shows that stage 2 is pulmonary. So that stage 3 is when you have severe hypoxia, and initially stage 3, the initial stage or A, that's when you have capillary leakage from the cytokine storm. And then as this gets worsened and if we don't stop it, it goes into alveolar injury. And that's what you see in the end stage is the ARDS. And if you look at the picture on the right too, it'll kind of give you the reason why we do certain antibiotic medications to help with this disease process. Next slide. So the sign and symptom kind of correlate with the process. Initially you have the mild symptoms, and some patients, like I say, are totally asymptomatic. But usually the triad, the 80%, more than 80% symptoms, or the triad we like to call it, is fever, cough, and shortness of breath. And so this is how we been kind of like screening people all everywhere. However, there's rigor, malaise, body aches, any upper respiratory symptoms. And then there's also symptom of GI as well, which is about, up to 20%, your diarrhea, nausea, vomiting, abdominal pain. And interestingly, about 5 to 10% have altered taste and smell. And that's, kind of pathognomonic for this disease. I can talk about this in a little bit. And then when it gets, as the disease progresses, the symptom can be severe, and it's mainly respiratory with hypoxia, and then eventually it affects other organs. With COVID-19, there's a term that a lot of people use called silent hypoxemia, and you probably have seen them in the ERs, particularly where they come in huffing and puffing with a respiratory rate of 30, in the 30s, satting high or mid, 80s, but they look okay. They don't look blue. They don't look like they're dying like your normal respiratory failure patient. So that's why it's called silent hypoxemia, where, they look like they're in respiratory distress, but the patient themselves don't look like they're going to go into respiratory failure. Generally, for recovery, we use the 2 consecutive negative PCR testing and clinical improvement. And like I say, the initial data report coming out of China in February of 72,000 cases, 81% were mild, 14 were severe, 4% was critical, and then between 0.4 to 1% is fatal. Next slide. So in terms of what I told you about, like the smell and taste alteration, statistic-wise, 10 to 15% prevalent, more male being affected and more white than non-white. And it's not really, COVID-19 that causes. Other coronavirus have caused it, and also H1N1 viruses have causes too. So the research here has been, in the previous as well, but the only thing is the percentage is more in COVID-19 than in previously, reported with other coronavirus and H1N1. And the reason being is that there's ACE2 receptors in the sensory neuron, in the olfactory and gustatory, or the taste pathway in the nasal epithelium. And these cells in the upper airway, neuronal cells, the sustentacular cells, they're the kind of like the support cell for the sensory neuron, and they help with the cells to reproduce, the neuron to reproduce, and pretty much overall support the health of the neurons. And so the rate of these cells dying and how well they replicate accounts for whether the sensory and taste and smell alteration, whether it's partial, complete, or whether it's permanent. And there's still study being done to see the long-term effect of this. Some patients report improvement in weeks, months, and some haven't recovered, their sense of taste and smell yet. Next slide. So when it becomes multi-organ involvement and multi-organ and organ failure, pulmonary, the lungs are, the one being affected. And then, of course, renal failure, a lot of heart issue in terms of heart failure. There's also neuroinvolvement with stroke-like symptoms, DIC, of course, mesenteric ischemia, and toxic shock syndrome. Next slide. So the primary organ that's being involved, and it's because of the entry of the virus into the body, which involve the respiratory tract. So the first organ that it will hit is the lungs, and it's the alveoli. The alveoli can trigger extreme inflammation just because it's such an essential organ, and also the gas exchange of the alveoli. So usually pulmonary or ARDS is what kills the patient. And there's a direct injury to the pneumocyte 1 and 2 in the alveoli. Pneumocyte 1 is responsible for surfactant. And when it's injured, you're not making enough surfactant, and so you cause atelectasis, and eventually it hardened the membrane of the alveoli, and this, the hyaline membrane, and this eventually will affect the gas exchange. We're going to talk a little bit about the vascular issue in this virus due to cytokine storm and also direct endothelial injury, but there is also vascular issue, what we call vascular de-recruitment. And what that means is that when there is not enough flow because of microthrombi, there is not good air exchange, and the alveoli is also being injured. So both atelectasis and vascular de-recruitment is what increase your dead space ventilation. That's what caused the hypoxemia in this patient. Okay, next slide. And of note too, just want to talk, briefly about pediatrics. So pediatric, they have less mortality, especially from age 1 to 10. mortality rate as seen right now is 0.4 to 0.6%. However, that mortality can increase up to 50% if it's, if the child's less than 1 year old. I guess it's because of their immune system. What we see in kids has been mainly, a lot of Kawasaki cases, but we're also seeing systemic inflammatory syndrome in kids as well. And this is kind of similar to adult. Adult, we call it the cytokine release syndrome. But characteristically, all these, pediatric patient has persistent fever, rash, and abdominal pain. And about 10% to 20% have cardiac involvement. They rarely have, interestingly, respiratory symptoms. And there's also, post-infection inflammatory syndrome. And they think that this multi-inflammatory symptom in kids and Kawasaki is a post-inflammatory syndrome because a lot of these kids are tested negative with the antibody for COVID. And just like Kawasaki, there's eye involvement, upper respiratory tract involvement with lymph node, and a lot of them do develop coronary aneurysms. So you have to follow up with them and echo and start them on aspirin. And they have the rash on their SOM and so. Okay, so next slide. So diagnostic study, of course, is PCR of the respiratory tract. There's several modes. The most accurate is the bronchoscopic lavage, where we, intubate a patient. We take sample directly from their lungs, and also tracheoaspirates as well if they have a trach. The FDA recommend the non-invasive in terms of like bronchoscopy is the nasal swab because it's easy and it's a simplified collection. And in terms of urine, fecal, pharyngeal, and saliva, they found out that the nasal swab contained the most virus. We've also been doing antibody study, but these are not accurate. And it takes up to at least 4 days of the infection for the antibody study to be meaningful. And of note too, initially when the pandemic started, our nasal swab have like about 20 to 30% false negative. So even though they're negative and they have symptom consistent to COVID, we assume that they have COVID. In my experience, sometimes I swab patient in the ICU, and it may take up the third or fourth swab before it becomes positive. But, with during this time too, you can do antibody study to see if they have it in, antibody to it. And in terms of prognosis, we generally get the coagulation study, the coag study, the D-dimer, fibrinogen, CRP. Study have shown that, the higher your D-dimer and your CRP, the higher your mortality is and the higher risk of respiratory issue that you're going to get. Okay, next slide. In terms of radiographic study, chest x-ray is what we often get. And usually they have the characteristic of the peripheral and kind of like lower lungs opacity. And that's not, particular to COVID. It's just particular to viral pneumonia. And when you get a CT, you'll see that too. With the initial study from China and Italy, you will find about 30% of peripheral ground glass opacity. And usually when there's consolidation, viral pneumonia, you will see it in the lower lobes particularly. And this is mainly because of the vascular de-recruitment that I told you about, which is particular to the lower and the dorsal lungs. And other modality that you can use is ultrasound. If you don't see anything in the lungs and you're waiting for the CAT scan, you can actually put a probe on the lung and see B lines. B lines are just, interstitial fluid. And sometimes if you go lower or different lobes of the lung, if you see consolidation, you'll be able to see it on the ultrasound as well, which is quick and easy. Next slide, we're going to talk about management. So the main management for this has been prevention and control with public health measure. But, global, national, and local enforcement kind of varies. And study have shown that when you really enforce, social distancing, self-quarantine, and mask requirement, you decrease the replication, reproduction number, which is the row. If you look at the right upper, if there is social distancing within 30 days or social isolation, you can really reduce the transmission rate to 75%. And if there's no social distancing or isolation or self-quarantine, you can have a pretty good number in 30 days. And the bottom number just show you like outbreaks with restaurant and just some statistic about that. If you have time, you can look through that. Next line. Of course, the most high-risk area would be anything in closed space with a lot of people, and the low risk is anything open, open areas and less amount of people. And in order to break the change of, transmission for the infection, you have to identify of course, the infectious agent, the reservoir, the transmission modality in terms of, how it's transmitted, and control the mode of the transmission, which is contact, mainly, and airborne precaution. Next slide. If you look at this in terms of mass, and they've done research on this, if both the carrier, the infected carrier, and the person who don't have the disease, if both wear masks, you can decrease the transmission rate to about 1.5%. And if you incorporate, social distancing with that, you can significantly decrease the rate of transmission and infected case. Next slide. And, in management, we have to protect ourselves too as providers. So, when a patient is in a room or they come in, put them in a room with contact and airborne precaution. Very, very important is hand washing hygiene and avoidance of touching faces. That's why we encourage, we should mandate that, provider and patient wear surgical masks. Not only would, decrease the amount of airborne with breathing and coughing, but it also reminds us to not touch our face because there's a physical barrier on our face. And the other important thing is, your daily routine of seeing patient, managing patient, you should adhere to it so that you have a, repetitive routine that you follow. And of course, protective equipment is also important. Having eye shield, N95 gloves, and patient with surgical masks. And the other thing that's important too is knowing how to put on and take off your gowns and your mask without contaminating yourself. Next slide. So let's talk a little bit about pharmacology. The slide earlier about the stages and what medication to use, just look over this. And then the next slide would be kind of like mechanism and why these medications kind of come into effect to slow down the virus. Next slide, you should also have a little understanding or visual understanding of the innate and adaptive immunity that we discussed in the phases, stages of the disease. Okay, next slide. So the mainstay state therapy has remained supportive. And I mean, in the past with the other viruses, Corona or H1N1, it has always been supportive. Everything else is kind of like, adjunctive management. Like I said, there's really no consistent pharmacological therapy. It's only symptomatic management, organ-targeted management, and judicious fluid balance, since the virus does, have a severe effect on the lungs, and control any superimposed infection. The pharmacological management that I will go through, it's recognized and the guidelines of the U.S. National Institute of Health, but it's also recommended by the WHO as well. In terms of supportive care, when patients go into hypoxemic respiratory failure. The initial stage is the atelectasis with interstitial hemorrhage. The alveoli itself is intact, but with time, there's alveolar injury and hemorrhage, and that's what we see in ARDS. Proning have, been shown in previous studies, especially with ARDS, to be very effective. What it does is that it decreases your VQ mismatch, which is ventilation and perfusion. And that in turn improve your oxygen and your, ventilation, which is CO2. And the current studies for COVID-19 and have shown to decrease escalation of O2 support and the need for intubation. And you can prone patient awake or intubated. And, we would recommend that you start proning them as soon as you have them in the ER or on the floor when they require supplemental oxygen. High flow nasal cannula have shown to significantly decrease your oxygen escalation. And so, there's really no recommendation at this point. Generally, how I and other intensivists have been doing is that if a patient require more than 4-liter nasal cannula and they're only satting low 90s, it's time for them to be on high flow. Now, there was a concern, and there is still concern, the high flow and the non-invasive ventilation like BiPAP, helmets, and CPAP can actually aerosolize the virus, but it's not as much as we thought it was initially. So if a patient is in a closed room, it's pretty safe to do it. And if you have, if they're in a negative pressure room or even a partial negative pressure room, you're definitely pretty safe. But the earlier that you start them on high flow, the better they will be, the better that they will not need, non-invasive ventilation and mechanical ventilation. So once they fail, high flow, you can go into BiPAP, CPAP, helmets, and then after that, you just got to intubate them. And particular to this virus, that's different from SARS in 2003, is that they don't initially act like ARDS. They act like non-cardiogenic pulmonary edema. So you can still set them at the lung protective strategy by the ARDS Foundation, but you can go up to 10 cc per kilogram of ideal body weight and not go to the 6 cc. Majority of the problem initially is atelectasis and the interstitial edema. So lower PEEP is better for them, not higher PEEP like ARDS, because lower PEEP will prevent alveolar injury and hemorrhage. And this is what happened initially when at the beginning of the pandemic, when we intubate them early and we start them on ARDS protocol, patient has significant mortality. I would say greater than 80%. But when we start treating them, now in the initial phase of respiratory failure with, generous tidal volume and lower PEEP, and treat them almost like pulmonary edema rather than ARDS, they tend to do much better, and we can extubate them, quicker. But however, just be mindful that they, as disease progress, they will go into ARDS, and then, at that time, we do initiate the ARDS protocol. For people who are intensivists out there, as the APRV mode of ventilation has been most effective in these patients because it allows them to spontaneously breathe. And also have some, ventilatory support as well. And of course, last resort is ECMO. And right now, we don't really have any indication if a patient is salvageable and they're young, we can ECMO them to try to save them. And ECMO, of course, is just, your cardiopulmonary resuscitation, heart and lung bypass machine that help the lungs to recover while they still get, respiratory support from the ECMO machine. Next slide kind of gives you, you can go next slide. give you a picture of all the modality. In Italy, because they didn't have a lot of CPAP or BiPAP, they used a helmet-based ventilation, and that's kind of similar to your CPAP and BiPAP. And it's actually, the helmet one, it's actually more comfortable. And even if they're on BiPAP, CPAP, or helmet, they can still be prone. But the high flow nasal cannula works best because they can be prone with that, which is much more comfortable. Next slide. Prone works is because of the west zone in the lung. I don't want to go into that because it can get a little complicated. But when we're in supine position, the dorsal lung with gravity gets the most perfusion, and if there's edema from infectious sores or whatnot, it will pull down to the dorsal lung. And so if you prone them, you kind of distribute that, and so you improve like the perfusion, and therefore you improve the gas exchange. With an awake patient, you can have like a donut hole to put their face through, even if they're on CPAP, nasal cannula. You can still prone them. The time and frame for proning is really depend on how much the patient can tolerate. If they can tolerate a few hours, as much as they can tolerate, prone would be, and keep them in that position. And after that, you can put them in lateral recumbent and upright, Trendelenburg, and then supine, and go through the process again. But the other, position, you can put them in, an hour or two, but the prone would be the longer, if the patient can tolerate. Next slide. So in terms of drugs, hydroxy chloroquine and chloroquine has been in the news at the beginning of this pandemic. We usually mainly use it for autoimmune disease, particularly lupus and rheumatoid arthritis. And it works for viruses, viral infection as well, and malaria. It's because, like I mentioned before, the virus, when it entered the cells, it encoded itself with the endosome, and this process, acidified the virus acidified the endosome in order to get into the mechanism of replication. So hydrochloroquine, what it does is it increases the pH of the endosome, and that will inhibit the viral entry into the cellular mechanism. And the medication also decreased the immune cells activity, particularly the macrophages, which what recruit the T cell, the neutrophil, and also release some cytokines. However, in terms of high doses, in order to treat this, in terms of, you have to really put them on a high dose regimen. And when you're on a high dose regimen, you can have prolonged QTC and put them in torsade and sudden death. And you can also cause long-lasting, eye issue and liver and renal issue as well. Next slide. So initially, the hype about these two medication was from a French study in March that advocated the use of hydrochloroquine and azithromycin, and it was published in The Lancet in March. And what they shown is that it significantly decreased viral load and symptoms of these patients. And the doses are pretty high. It's 400 milligram twice a day, day 1, and then 200 milligram twice a day, day 4. Chloroquine is a little higher. And for the autoimmune disease that, we use it to treat it, the doses is almost half of that recommended, for COVID. And this French study did the study is because, there's anecdotal case studies in China, in January that shows that, some patient who were on this were getting better. And the Chinese used the data from SARS in 2003 to kind of investigate this. However, that French study that a lot of people use as kind of like the therapy, the standard, was a small population. It was like about 90 patients. The way they did the study was not great either. The methods were not great. And actually, like in June, the Lancet actually retracted the study because of how bad it was. Subsequent, large randomized controlled trial by the Chinese, the French, and the Brazilian did not, in large study, did not show any clinical benefit. And there's actually a trend toward increased mortality, ICU stay, hospital length of stay, and escalation of oxygen requirement. And the increased mortality is due to the arrhythmia with Torsades. And so the FDA, they did an emergency use in June, and they revoked it by July, essentially. And the European and the WHO did the same thing. If you look at the right, the first illustration is the what the French study did. That small open trial. And then once that study came out, you can see the hydroxychloroquine and azithromycin, prescription dispense has gone up like more than 1,000-fold. Next slide. So let's talk about antiviral. The only antiviral that seemed to be somewhat effective is remdesivir. They have tried, HIV medication. They have tried Tamiflu for flu, and it doesn't really give any good evidence. So currently, the regimen is 200 milligram day one, and then 100 milligram daily for 4 days. And they have been using this medication in hepatitis C and Ebola, and really haven't shown any concrete evidence that improve anything other than the viral load improvement. So the NIH, there has been study out. The largest trial, a lot of them were small, randomized controlled trials and observational study that did not show any benefit. However, in April there was a large trial involving 1,000 patient, what we call the ACTT-1 trial, and that's the adapted COVID trial treatment. Sponsored by the NIH and also the National Institute of Allergy and Infectious Disease. And it shows that it hastened the recovery time from 1 to 4 days, but there's really no significant mortality benefit day 14 and 28 day. And there's no clinical significance in people who require non-invasive oxygenation, mechanical ventilation, ECMO. It only benefits those who require supplemental oxygenation. There is a trend toward reduction in mortality, but the study did not show any statistical significance. And the follow-up trial called Simple Trial, which is a smaller study, did confirm the same thing. However, it showed that because the ACTT trial did remdesivir for 2 weeks, this follow-up Simple Trial showed that there's benefit with a 5-day regimen rather than the 2 weeks course. So because of this trial, the ACT-1 trial, the NIH recommended that, a 5-day course for people who require supplemental oxygen will help improve the recovery time. But again, there's insufficient data for or against its use in terms of mortality benefit. Next slide. So as I mentioned before, because of these cytokine and also direct viral injury to the endothelium, there has been, micro thrombosis. And we've seen it mainly in postmortem studies where there's microthrombus in the lungs and in other organs. And we have seen that, patient has, significant rise in their D-dimer, and we initially thought that it was mainly from inflammation, but now there's a contribution for thrombus as well. The main course of the disease, it will eventually lead to DIC, but initially it does cause thrombosis. So there's really no consistent guideline on when to start prophylactic DVT versus full therapeutic dose for DVT NPE. Some people use a DIC score, the ISTH6 score, with the criteria for severity. If you have a score of greater than 4 with the DVT, criteria, then you should really put them on, like, full dose anticoagulation. And there are cases where we actually TPA people, and I've myself TPA'd 2 patients who have significant hypoxia, even on mechanical ventilation. The only thing that would have saved them is, this attempt, and they actually got better. And there's a newer study that's, trying to see if we can nebulize TPA rather than do the systemic one. And of note too, heparin and Novalox has been good, but you can use other, blood thinner like Eliquis or Xarelto. And both heparins and the non-molecular weight heparin, the Lovenox, actually have anti-inflammatory and antiviral properties. So we tend to use them more. And Lovenox is actually, the pharmacokinetic is more consistent, so we don't have to measure the PTT level like heparin. So this overall decreased patient and provider contact. So we prefer to use Lovenox if we can. Next slide. This is just a slide, about immunomodulator to inhibit some of the interleukins and the tumor necrosis factors that is central to the cytokine storm. Okay, next slide. So the first immunomodulator is steroids, and timing is really key. So during the first phase of this disease, the innate immune system kicks into play, and to help decrease the viral replication. And in the study from 2003 with SARS, using steroids decrease viral clearance, and they have a worse outcome. However, we didn't really map out the stages, and and with this, initially at the beginning of this pandemic, we were not using steroid because of that. But then when we start thinking about the stages, we actually time it so that once the innate system, if you give steroid during the innate stage 1 phase of the disease, it will increase the viral load, and so it will make things worse. But if you start into stage 2, usually the 5 to 7 day, and that's usually the time when the patient come in the hospital anyway. So if you use steroid then, you can decrease the cytokine release and help them recover. And this is what the recovery trial that was done in April show. It was a UK National Health Institute with a population of almost 6,500, multi-center randomized, and it shows that there is a mortality benefit of 8 to 26% with people who require oxygen. And the dose that they used was based on previous trial with ARDS was dexamethasone 6 milligram daily for 10 days. It's shown that it benefit, 76% of people who are on oxygen have benefit in terms of recovery time, mortality, and also escalation of oxygen than people who don't require, oxygen. And some places will actually do the high dose dexamethasone rather than the lower dose of 6 milligram. Some places would do 10 to 20 milligram daily for 7 to 10 days. And this is based on the ARDS trial a couple of years ago. And usually when we do, I've done it myself, and I use clinical status of the patient and also inflammatory marker of the CRP, D-dimer. So based on the recovery trial, the NIH recommended that those who require supplemental oxygen, especially mechanical ventilation, this will be useful. Alternative steroid that you can use is prednisone, methylpred, and hydrocortisone. The reason dexamethasone works well for these patients and patient with ARDS is that it doesn't have mineralocorticoid property, and so it doesn't retain fluid. And these patients, because of the lung involvement, you want their lungs to be as dry as possible. And that's why judicious, fluid balance is important for supportive care. So next slide, the cytokine release syndrome. So there's 4 interleukin that have been, central in previous autoimmune problem and previous, cytokine release syndrome diseases. The first 2 that we have been measuring in COVID-19 that have been elevated is interleukin 6 and 1. So interleukin 6, the dose generally is 8 milligram per kg divided into doses for every 12 hours. The Convecta trial with this of 450 people with severe disease did not show any benefit at all. It did decrease the inflammatory markers within 24 hours, but there's no benefit, and there's possible poorer outcome due to liver failure. So the NIH does not recommend any interleukin 6 inhibitor. Interleukin 1 inhibitor, the dose is right there. There's a case study of 94 patients that they looked into. It did, just like the interleukin 6 inhibitor, decrease the inflammatory marker, but it did not show any meaningful benefit. And there are actually higher rate of bacterial infection and DVT than this placebo care. Okay, next slide. Another, a cytokine that's also important is the tumor necrosis factor alpha, and this is released mainly by the macrophages and the T cells. So we've been looking, and usually we use anti-tumor necrosis factor in people who have inflammatory bowel disease or severe psoriasis. Through the Global Health Rheumatology Alliance, we looked into retrospective case series, and out of the 77 patients who were positive for COVID, who have some sort of, inflammatory bowel disease, the one that are on anti-tumor necrosis, like Humira, Remicade, or Enbrel, they have like a lesser, mechanical ventilation rate and mortality than the people who are not on it. So currently there's a couple of trials all over the world that trying to look into this with randomized controlled trial to see if it's, meaningful. Interferon type 1 has antiviral function and some anti-inflammatory role. We mainly use it in hepatitis viral, viral disease, and also MS and some autoimmune disease. There's 3 types. Beta is the one that we look for, and retrospective study at the beginning with the Italian and the Spanish show that for patients who have severe COVID, it decreased their symptoms and questionable mortality, but that's not significantly, statistically significant, and there was no change in terms of recovery time. And there's been looked into like interleukin 8 and 12 and these tyrosine kinase receptor inhibitor, but that's still, in the research process. And so for these cytokine, the NIH does not recommend for it or against it because of insufficient data. The only one that they will recommend is interferon beta, which, help with the symptoms. But they're definitely against, interleukin 6 and 1 inhibitor. Next slide. So what's been on the news lately is convalescent plasma. So plasma from that has antibodies from survivor of COVID. And there was a emergency, use authorization by the FDA that was in August. We've been using it for other coronavirus and along with Ebola, but it didn't really show any meaningful outcome. Currently, there's really not a lot of data. But the NIH the FDA did this emergency use authorization based on this study of 103 patients in Wuhan that, did show some mortality benefit, but it wasn't significant. The only issue with this study is that there was an early termination. It was not blinded, and standard therapy was not protocolized. And so, but then the Mayo Clinic did have a study recently, a case study of 5, which what you see in the right upper corner. They had 5 critically ill patients with ARDS, and out of the 4 out of 5 did have a sequential organ failure assessment score that's improved within 3 days, and their oxygenation has improved over 12 days. And 3 were discharged from the hospital, and 2 were stable after the plasma infusion. So all over the world, there has been intense research on convalescent plasma. Next slide. I know we're running out a little bit of time, so I'm going to speed through these slides real quick. So this talk about the anticoagulation and the hypercoagulable state of COVID. If you look over to the right upper, overall, like there's 20 to 30% prevalence of DVT and PE with COVID patient, and about in those cases of vascular thrombosis, 80% are PE, which makes sense that COVID target the lungs. So the possible mechanism is direct endothelial injury by the virus, excess angiotensin II level due to the ACE2 receptor inhibition, and the cytokines. And the marker that we use, of course, is D-dimer, fibrinogen, and the coags. Like I say, the NIH doesn't really recommend for or against, and based on providers' clinical suspicion to start, full dose anticoagulation. Next slide gives you a little bit of information about the mechanism, which is not fully understood yet, but this is kind of like the theory of what's going on, why these patients have microthrombosis and thrombosis. Next slide. Other stuff that we have used to modulate the immune system are vitamins, vitamin C and D particularly, because it has anti-inflammatory effects, and it has a role in cellular immunity and vascular integrity of the cells. So less inflammation and less vascular injury causing thrombosis. Vitamin C particularly is a full factor for catecholamine, and so people have and it has been widely studied, and it's been studied in sepsis as well. But in the burn literature especially, vitamin C has been highly studied, and it shows that people who are on it, especially when they're severely sick, they require less fluid resuscitation, less pressure resuscitation, and a lot of them can get off of ventilator quicker than others. But the study has not shown to be conclusive about mortality benefit. And zinc have also been in place too because of cellular immunity, and especially with the interferon from the macrophages and the natural killer cells. It also has some role in blocking viral replication. And interestingly, that the quinidine that we put them on, like hydroxychloroquine and chloroquine, it enhances uptake of the zinc. So, that's another mechanism where hydroxychloroquine and chloroquine is able to improve, questionably cellular immunity and viral replication. The other thing that has not been on the news, but it's been studied, is mucimist and statins. Mucimist, we usually use it for liver failure patient because it increased the glutathione synthesis, and it decreased the oxidative stress, particularly in the lung, and it causes, it has anti-inflammatory property. We've been using it in ARDS, and there's some, benefit, clinical benefit, but again, no mortality benefit. And it just improves like lungs function. And statin is the same thing. It reduced symptoms severity, and then case study have shown questionable reduction in mortality, but it's not significant, statistically significant. So more study on these are being, studied in large trial out there. But at the beginning, and even now to the pandemic, we've been using vitamin C, D, and zinc on these patients with, and the NIH, recommendation is that they're not for or against it, just based on clinical provider, how they practice. So next slide, we're almost done. We'll talk about prognosis and research. So there's, since this virus caused, multi-organ, and now we're thinking about not just inflammation that's causing it, it's also the microthrombosis, causing stroke, causing renal failure, causing, GI issue like mesenteric ischemia. But in terms of like when these patient does develop, like for instance, paresthesia or the alteration in smell and taste, and pulmonary issue, we don't really know what is the long-term effect and whether, patient will fully recover. We will only know when the pandemic kind of like resolve and settle down, and we can, follow these patients, years out. But we do know from previous coronavirus infection is that, there's a huge toll on the lungs. A lot of these patients in the past have developed, pulmonary fibrosis and pulmonary hypertension. And, overall, this causes diminished lung function. And some would develop, obstructive disease. And this will lead into oxygen dependency and decreased quality of life. That talks about the pulmonary effects that I told you about. Next slide. This kind of just give you a picture of like, the initial injury, which is just the, an intact alveoli, but then you have the interstitial pulmonary edema. And then after that, when it's severe and as the disease progresses, it does go into ARDS. Okay, next slide. So there is about almost 3,500 global research right now. Most of them are in Europe, but the US is, secondary with 782. And this is data from October, at the beginning of October. And next slide. In terms of vaccine development, there's about 230 vaccines that are, possible, but only 28 are, in human trials. 28 is in phase 1, 11 in phase 3, and none has been approved yet. And the last report that we had from the National Institute of Allergy and Infectious Disease, and also the WHO, is that we might not get an effective vaccine, a safe and effective vaccine, until next year, or perhaps early next year, or even like the spring and the summer of 2021. I know that's a lot of information into one lecture, but if there's any questions, please let me know. And if you have time, I would recommend you go through the slide, like, at least twice, just to absorb all the information. Like I say, the information that I gave you today might not be, applicable, in the next few weeks, next few months. So make sure you stay current with the data and the up-to-date, management. Okay.